Thank you, James, and thank you all for inviting me to come and speak at this conference. I've already learned a lot having attended the sessions yesterday, and I'm struck by how many issues the U.S. and Australia have in common. So it's interesting to talk about this stuff with this audience. Now, I've noticed that the title of my talk is different in different places. Some places it's described as talking about healthcare costs, and others health reform. The two topics obviously are very closely tied together, so I don't think anyone who expected one or the other will be disappointed in what I'm going to present. I'm going to talk about some of the background on U.S. health reform, I guess otherwise known as Obamacare, although I think it will last longer than the end of this term of our current president. I also, while being struck by how many similarities there are in terms of the issues faced by the healthcare system in our two countries, I was struck by the fact that the new campaign for Prime Minister was announced the other day, and I was particularly struck by the headlines that described the 8-week campaign as a marathon. Those of you familiar with the U.S. political system know how much we envy you. So it'll be interesting to see how that plays out in both countries. So the first point, I think that everyone has accepted over time is that the U.S. has the most expensive healthcare system in the world. So this is a graph that my former colleagues at the Commonwealth Fund are very fond of presenting, and it shows the trend in spending as a percentage of GDP. For a select number of countries, including Australia. Australia's in there, in the middle, in the bunch somewhere. And the U.S. Clearly stands out in terms of what we spend. We spend at least 50% more than any other country in the world. So that's the first thing, and clearly the first thing that's driven a lot of health policy in the U.S. So the question is, what does the United States get for the money that it spends on healthcare? This level of spending certainly exacts a cost. I mean, not only financial cost, but it puts pressure and affects policy in all kinds of ways at all kinds of levels, including the federal, not only the federal budget, but our state and local budgets, and also businesses and particularly households in the U.S. It's all too often ignored the fact that households actually end up bearing all of the burden of healthcare spending in one way or another because they pay the taxes that support healthcare spending on the government end. They forego the wages that end up paying for their health benefits from their employers, and of course they pay substantial out-of-pocket for their health care. This graph is one that is a couple of years old, but the picture is, I think, still the same. It's an estimate done by the U.S. Congressional Budget Office that showed that even if nothing else in the federal budget in the U.S. Changed as a proportion of GDP, the growth in health spending would end up pushing the federal budget up above 30% in the U.S. Now, you have to understand when I talk to people from other countries, I have to explain that 30% of federal health spending in the U.S. is viewed with horror. It's not the case for most other developed countries, but that did sound an alarm, and it certainly shows a system that's not completely under control. At the state level, what this means is that an increase in proportion of state budgets is devoted to health spending, which means that other spending, such as public health, mental health, education, infrastructure, get bled dry because there's no money left to support that spending. And this is a case in point in Massachusetts, which actually is a fairly special state in the U.S. because Massachusetts actually predated the rest of the country in terms of the kind of health reform that we're seeing. Thank you. I'm reminded of a story that I don't know if you've heard about the problems with the water, lead in the water in Flint, Michigan in the U.S. And then President Obama visited Flint the other day, and his throat was dry, and he was coughing, and he asked for a glass of water, and the crowd went wild. And this is where the rubber really hits the road. For American workers, you can see here that workers' earnings rose by about 47% between 1999 and 2012, while their health insurance premiums rose by 172%. And their own contribution to the premiums actually rose even more than that as employers cut back on their subsidies for employer-sponsored health insurance. So it really does hit the American household in the end. So what do we get for this amount of money? The folks at the Commonwealth Fund put together a national scorecard on U.S. Health system performance and found that the grades we got as a system along 5 dimensions of what we'd want from a healthcare system end up being somewhat below what we'd want our children to bring home in terms of grades from school. And things, at least till immediately before the Affordable Care Act, weren't getting better. One example of that is a measure called mortality amenable to health care, and you can see the problem here. The U.S. On this measure in the mid-2000s was last among these 16 high-income nations in mortality amenable health care. That is the mortality in categories that were thought to be addressable by better health care provision. But actually, if you look at the white bars, things actually have gotten better across the board. And they got better, substantially better in the U.S., just not as fast as in other countries. And so the U.S. actually fell to last on this list in terms of mortality amenable to health care. There's also wide variation in quality and costs. It was interesting to hear people here talk about the relationship between quality of care and cost of care. This is from the U.S. Medicare program for the health care for the elderly and disabled, and you can see that the variation in cost, this is for 306 hospital referral regions across the country, and you can see variation in cost per Medicare beneficiary varies substantially. And variation in quality is also there, but not quite as much. But the thing that's striking here when you put the two on the same plot is that the relationship between the amount of money spent in different areas in the U.S. and the quality of care that is received by the people who live there doesn't seem to be there. There seems to be absolutely no relationship between the amount that's spent in different areas and the quality of care that's received. This is another important graph. Before the Affordable Care Act went into effect, the number of uninsured in the U.S. was over 50 million, and even more importantly, the number of people who were underinsured was substantial as well. This is people who actually had health insurance, but where the health insurance would fail to protect them adequately from the cost of the health care that they needed. Now, when I was at the Commonwealth Fund, and this, I guess I can use this opportunity to plug the International Health Policy Program that the Commonwealth Fund runs, and we always have people from Australia in the group that they have. When we would put this graph up at the orientation session for the international health policy folks, somebody would always raise their hand and say, do you mean to tell me that there are over 50 million people in the United States without health insurance? And we would kind of shrug because it's true, or it was true. And there would all be somebody who exclaimed, but how can you let that happen? And that really was the impetus for health reform in the US more than anything else. Of course, lack of health insurance has ramifications. People go without needed care because they don't have health insurance. People who do need care and can't avoid it suffer financial consequences from the debt that healthcare costs generate. We also have a problem with screening and preventive care. Of course, the emphasis of a healthcare system that spends a lot of money for procedures and services means that inadequate attention is given to preventive care. And that lack of attention is particularly concentrated among people who are uninsured and people who have low incomes. Paying for individual services means that you're not paying for the coordination of care. And that's been a particular emphasis over the last few years. Before the Affordable Care Act went into effect, there was a large proportion of US patients who were reporting that they had duplication of services, duplication of tests, lack of communication among the different providers that they were using. Another observation that's come to the front in the last couple of years is the relationship between health spending and social care spending. And I noticed there was a lot of talk yesterday about kind of reaching out beyond the hospital walls into the community to try to address preventive care and address the social determinants of healthcare need. And the US is particularly bad at that. We spend a lot of money on health care, very little money on social care that would support better health in our population. Now at this point I have to relate an anecdote. I was testifying and presenting this kind of information to our Congress, and there was a panel, and there were three people on the panel, and the presentations were all very consistent in, we're spending a lot of money, we're really not getting our money's worth in terms of what our healthcare system performs like. And at the end of the testimony, the chair of the committee summed up by saying, well, I think we've heard here that the US healthcare system is the best in the world and we don't want to do anything to mess it up. Protocol prevented me from asking the chairman what testimony he had heard. But that represents the level of denial that existed in the US about this information. And there's been a debate in the US about what drives healthcare. A lot of effort has gone toward been aimed at utilization and trying to eliminate unnecessary utilization, trying to get the care to the patient at the right time, and that's certainly very important. Much less effort has been placed on prices in the U.S., and prices in the U.S. are very high. There has been some work that's looked at that. There was a piece of work by several researchers in the U.S. that actually was sponsored by the Commonwealth Fund that came up with an article that's called "It's the Price is Stupid." And what it did was it compared price levels in different countries with price levels in the U.S. and found that a lot of the difference in health spending between the U.S. and other countries is accounted for by the high prices for health care in the U.S. And this is a set of examples. There you can see Australia's on that list. You can see that compared to other countries, the prices in Australia, now this is several years old before I'm sure the activity-based funding effort had its full effect. But you can see that whatever it is, the U.S. is just way off the charts here. So then we come to the Patient Protection and Affordable Care Act of 2010, otherwise known as the ACA, otherwise known as Obamacare. And what the ACA received most attention for was its emphasis on coverage, providing health care coverage for many of the 50 million Americans that had no health insurance coverage. But it also focused on a number of other things. A lot of people have criticized the ACA for not focusing sufficiently on the cost of healthcare, but in fact, there were several provisions that really did focus on efforts to control the cost of healthcare. There were foremost the creation of a Center for Medicare and Medicaid Innovation at our Center for Medicare and Medicaid Services, which is tasked with the job of developing and implementing and testing and evaluating and spreading different approaches to the payment, organization, and delivery of healthcare. There are also adjustments to basically make the statement that the U.S. has a right to expect a certain amount of productivity improvement in the healthcare system. There are attempts to increase the emphasis on primary care. In the U.S., for a long time, the proportion of medical students who've gone into primary care specialties has been declining. There was a very interesting article in the New York Times, very upsetting article, several years ago that showed that actually dermatology was the most attractive residency slot, and there were medical students figuratively lining up for dermatology slots. And you have to ask why not, because dermatology is well paid. Dermatologists don't get called in the middle of the night by teenagers worried about their acne. So why wouldn't they be attracted by that life where they make several times more than primary care practitioners do, and primary care providers do get called in the middle of the night, and they have to deal with those kinds of responsibilities and frequently make life and death decisions. So the emphasis has been to try to make primary care more attractive, but not only make it more attractive by money, because really the federal government doesn't have the money to make up the difference between what dermatologists get paid and what primary care physicians get paid, but to place primary care in the center of the healthcare system where it belongs, and also to improve payment. So there was a 10% bonus in Medicare payment for primary care providers that actually has expired now because it was in effect for 5 years. There was also in Medicaid, which is our program for the low-income families, although now it's expanded considerably under the Affordable Care Act. There was additional federal funding to bring Medicaid payment, which is run by the state, up to the level of what Medicare payment is. And that was a substantial boost for primary care in the states, especially primary care physicians who serve low-income patients. But that was only temporary as well. And there's a limit to what you can do. When I was at what's now the Medicare Payment Advisory Commission, the Medicare program decided that it was going to pay, because it subsidizes teaching hospitals, which is another issue that I see has come to the fore here. Medicare decided it was going to pay more for residency slots in primary care fields and less for more highly specialized residency slots. And what happened was two things. One is the pushback was really tremendously negative. We had medical students writing in outrage how the government had no right to tell them what specialty to practice in, when in fact they still could choose whatever practice they wanted. But and the second was that hospitals in effect shrugged their shoulders because a cardiac surgeon resident brings in so much more money than the difference in payment that Medicare was offering, that hospitals basically just said, okay, go ahead. We'll still rather have a cardiac surgery resident because they bring in hundreds of thousands of dollars in revenue to the hospital. So it's an ongoing struggle to try to make primary care the center, and I'll talk about some models that try to focus on bringing primary care to the fore. There are also a lot of efforts that have actually been underway for about a decade to tie together quality improvement with payment, and I notice that that's an increasing focus in Australia as well. I can tell you that when I was at CMS and we started, and I've always been a payment kind of guy, but we started talking to the quality folks to try to figure out how to tie quality and payment together. There really were two distinct dialects being spoken by the two groups. Payment people and quality people just couldn't communicate. And that has really improved substantially over the last 10 years in the US. Okay, so what's going on now? Well, as you may have seen reported in the US, health insurance coverage has improved considerably, although not as much as some of the proponents of the Affordable Care Act would have liked to see. Part of the problem is that there were populations that were explicitly excluded from the Affordable Care Act, including undocumented American residents. But also because our Supreme Court ruled that while the expansion of Medicaid was allowable, that the federal government couldn't coerce the states into expanding Medicaid. So a number of states have not expanded their Medicaid program, and that was supposed to account for about half of the increase in coverage in the US. And they've done so really on largely political basis, because the federal government has put a lot of money on the table for states who are willing to expand Medicaid, and still a number of states have refused to do so. You can see that the improvement in the proportion of adults who are insured goes across all racial and ethnic groups, and it's particularly strong in those groups that previously had most trouble obtaining health insurance and affording health insurance. And despite the fact that that Obamacare is viewed as an instrument of the devil by a lot of American politicians, the people who engage in coverage through the new marketplaces have viewed them fairly favorably. There are substantial subsidies for low-income people to obtain health insurance coverage, and one of the more controversial issues is that there's a requirement that every American that's got an income above a certain level obtain health insurance coverage, or else they have to pay a penalty. But the penalty actually, admittedly, is fairly small, and a number of people still are deciding to pay the penalty rather than to spend the money for health insurance. As I said, many states have refused to expand our Medicaid program, and you can see here the price that they pay, or at least that the price that their people pay. States that did not expand Medicaid have substantially higher uninsurance rates and substantially less improvement under the Affordable Care Act than states that did expand Medicaid. Payment and delivery system reform is, as I said, a major effort, a major focus of the Affordable Care Act. And there are a number of models that are being implemented and tested. As I said, primary care is a major focus. And the patient-centered medical home model, which puts the primary care physician as the primary care provider, actually, not just physicians, at the center of helping the patient navigate the healthcare system, and provides payment for providers who do that, who provide that service, has been developed and implemented widely, and there are mixed results from different models, and those are still being experimented with. There's an initiative across the states that is referred to as a Comprehensive Primary Care Initiative, where again, providers receive additional payment for providing services that go beyond just providing healthcare services, providing advice to their patients. And this brings to mind another emphasis of the Affordable Care Act. Unlike many other attempts to reform the U.S. health system, or at least to modify the U.S. health system that tended to focus on the federal side, there have been many new initiatives that actually recognize that it's at the state level that a lot of progress can be made. And the Comprehensive Primary Care Initiative is one of those. Accountable care is a catchphrase in the U.S. That's also very popular, but also very controversial. The Accountable Care Organization, or ACO, is a model that's really caught on across the U.S., not only in the Medicare program through the Medicare Shared Savings Program, but and other models, but also in the private sector. And there are hundreds now of accountable care organizations participating in these models and involving millions of patients. The core of the model is that if the organization, it's an organization that includes not only the hospital, but other providers, physicians, and other providers at all different levels, and they get rewarded if they can reduce total costs for the patient, not just hospital costs, but total costs for the patient, and they can share in those costs. And there are different models. Some of the models only provide for sharing for savings, but don't have a penalty. Other models provide higher shares of savings in return for being willing to pay a penalty if you don't achieve those costs. And all of them are tied to quality measures. So you don't get your shared savings if you achieve savings, but you don't improve quality of care. Bundle payment is another issue that I've heard discussed here, and it's another focus of our policy. Recently, the Bundled Payments for Care Improvement Initiative, is a voluntary initiative that is demonstrating what happens if you pay for bundles of care rather than individual services or individual hospital stays. And more recently, the federal government has announced a comprehensive care for joint replacement demonstration that is actually unusual because it takes a handful of areas across the country and involves mandatory participation by providers in those areas, which is hardly ever the case in Medicare demonstrations. There are other private initiatives as well that I should mention. One in the state of California, the Public Employees Retirement System in the state of California said, we've studied the relationship between price and quality in joint replacement in our hospitals, and we found that there is no relationship to speak of. So what we're going to do is we're going to set a price equal to the 75th percentile of the distribution across all hospitals. And if you want to go to a hospital that charges less than that, then we will cover your costs. If you want to go to a hospital that charges more than that, we will cover up to that amount, and then you have to pay the difference. And the results of that policy were twofold. One was there was a massive shift of patients from the high-cost hospitals to the lower-cost hospitals. And two was that the high-cost hospitals ended up cutting their costs. So incentives do work occasionally, and we do get what we pay for. Value-based purchasing is another phrase that's, it used to be called pay for performance. It's somewhat controversial, partly because many studies have found the lack of relationship between paying for metrics of quality and improvements in quality among those providers. But my reaction to those findings tends to be exactly how is paying for better performance a bad thing? And in fact, I'd like to point out that we pay for performance now. We've just generally paid for volume rather than for quality. So the question is, how do we get to better measures of what we want to see the healthcare system produce, and how do we tie payment to that? And then there are a number of initiatives being pursued that involve multiple payers, not only public payers, not only Medicare and Medicaid, but private health insurers. And as you may know, in the U.S., we have an extremely fragmented healthcare financing system, as well as an extremely fragmented healthcare delivery system. And there's some attempt here to try to get folks to at least be pulling in the same direction when we're talking about improving healthcare. The Secretary of Health and Human Services, our health minister, announced last year that Medicare was going to focus on moving away from our traditional fee-for-service-based payment system to payment tied to quality or value. We have moved in the beginning of this year. The Secretary announced that we had achieved our goal for the end of 2016, so we're actually a little bit ahead of schedule. But of course, the question is whether tying payment to quality or value, what exactly that means, and that still remains to be sorted out. As I said, the Center for Medicare and Medicaid Innovation is a major provision, perhaps the most important provision of the Affordable Care Act. It's the mission of CMMI, and I heard somebody mention CMS before, and they mentioned that CMS stood for the Center for Medicare and Medicaid Services. There was a lot made when that agency was renamed in the early 2000s of the fact that it only had one M. Because Medicaid has tended to be kind of relegated to second-tier interest in the U.S. Medicare is a nationwide program. Medicaid depends on what the individual states do. It's a federal-state partnership. When they formed the Center for Medicare and Medicaid Innovation, they made sure to include both M's here. But there's a challenge, and as a health services researcher, and those health services researchers who are in the audience will recognize this, trying to improve healthcare is an easy thing to state, but actually doing it and figuring out what works is a very much more challenging thing, especially in an environment like we have in the U.S. right now, where we have a whole variety of initiatives that are attempting to change healthcare. And so I remember when I was at CMS and running the Office of Research, Development, and Information, we would constantly be hearing from our evaluators of the demonstrations we were developing, and they would be pulling their hair out because they'd say, look, we designed this demonstration, and now you're implementing it, and because it's in the real world and not in a laboratory, you're actually having to make some modifications as you actually implement these demonstrations, but you're contaminating our evaluation. How are we supposed to reach conclusions about whether this works? And that's a challenge that you always face when you're trying to innovate in a messy system like healthcare. And it's something, there's a real, we ended up coining the phrase, we wanted to find the balance between methodological rigor, which is certainly important in evaluation of new innovations, and policy rigor mortis. Because you start worrying so much about keeping pristine your evaluation of the demonstration that you end up making your demonstration less effective. And then that becomes compounded when you have multiple evaluations going on at the same time. How do you tell what is attributable to what? When I was at CMS, and this was from 2002 to 2005, we actually had a rule, and it was a long-standing rule, that you couldn't do a demonstration in an area where there was another demonstration going on. That's clearly not the case anymore, and it can't be the case anymore. But that really makes it difficult to do the evaluations. And what you end up doing is being biased toward failure to find successes, because you can attribute the changes going on to any particular innovation. So that's something to really be conscious of when you're talking about changing policy. And then, of course, once you figure out that something might work, how do you spread those innovations? How do you get other people to adopt those innovations? It's easy if you want to pass a national policy to require something, but that's not always possible. So where does this leave us? Well, we've also experienced a slowdown in cost, and I kind of flinched when Mr. Solomon presented the data on costs in Australia, because one of the things we've had to deal with is people look at the cost slowdown in the U.S. and they say, well, yeah, but that's true worldwide. And trying to convince people, well, that may be true worldwide because people are trying things all across the world. It doesn't mean that these things don't work. It means that you have to try all these things. But in any case, we have had some success in holding Medicare costs per beneficiary down. Although we do have an increase, as most countries are having, an increase in the proportion of the population who are elderly. And that's, actually, let me go back. And that's a problem, because that means that our Medicare costs are actually projected to rise faster than GDP, even though on a per beneficiary basis, they're actually rising very slowly, if at all. So you come to what we call the $2 trillion question in the U.S. If you look at the projection of national health expenditure in the U.S. From 2010, right before the Affordable Care Act was passed, to 2020, you find that, and then you compare that to the actual experience in the years that have already passed, and the new projections of healthcare spending growth, you find that the difference in health spending between the two lines is about $2 trillion. So somewhere we've managed to reduce health spending over a 10-year period by $2 trillion. The question is, what have we done that's worked, and what should we do in the future? And that's the thing that's really controversial in the U.S. Another thing that I must mention here is that we are always hearing, I go to conferences in the U.S. all the time and hear talk about how we're facing, if we're going to slow down healthcare spending, we're facing a situation where there are going to be pitched battles between providers and payers, and there's going to be blood running in the streets with all of the policies that we have to pursue to slow health spending. But if you look at this chart, you notice that even in the lower line, you're talking about $32 trillion in health spending over a 10-year period. I don't foresee a situation in the U.S. where you're going to have cardiac surgeons selling pencils on street corners. And I keep having to remind people of that, because when you're talking about this, they're talking about taking $2 trillion out of the health system. Oh my God, we're going to kill people. We're going to put providers out of business. We're not talking about that. We're still talking about, even if we succeeded in holding health spending growth in the U.S. to the rate of growth of projected GDP, we're still talking about something on the order of a 50% increase in health spending over a 10-year period. That's a deal that many U.S. industries would be willing to sign right now. But only in healthcare is a 50% increase over 10 years referred to as a shrinking pie. So we have some education to do, and a lot of it is addressable with data like this. And again, we have a projected slowdown in health spending, but the projections tend to be, or we have a projection of health spending, but the projections tend to be high. The thing about projections is they work really well if nothing changes. But if they change, somebody used to brag that they had predicted 12 of the last 10 recessions. And again, here are the numbers for Medicare spending and how you have a real disconnect between the number of the per capita health spending projections and the total health spending projections, which are substantially higher than GDP growth. Another thing that I have to remind my colleagues of is that the fact that Americans are living longer and that there are more Americans who are older is a good thing. We keep referring to it as though it's a bad thing. And that perhaps if we've made a social decision to produce more elderly people, that we ought to face the fact that we might want to devote more of our resources to those elderly people. Also, there was an interesting article that I saved in my files from about 15 years ago that pointed out that for a typical American family, they used to have, on average, about 2.5 children to raise, put through school, and set up in life, and about 3/4 of a parent, because people weren't living as long. Now, that's kind of flipped. They tend to have, 1.5 parents and 1.5 kids. But the total burden on a family, on a working family, is actually fairly constant. So while we talk about the fact that in the U.S. we're going to go from a peak of 4 workers per elderly person to what's projected to become 2 workers per elderly person, and how are we going to be able to support all of these elderly people, I would posit the answer is not to stop growing older. I would posit that the answer is to look about how we allocate our resources. Now, that doesn't mean we should spend an infinite amount on elderly people, although as I get closer to that age, I'm more comfortable with that thought. But it means we need to really do some rational thinking about how we allocate our resources as a society, and that's not unique, of course, to the U.S. And again, we have projected government deficits, which is a very important thing in Washington. This does not, by the way, include the cost of building a wall between the U.S. and Mexico. So, what do we have to do? We really need to figure out ways to maintain or improve quality while controlling costs. We've got a problem there because, on the one hand, quality costs money. On the other hand, it's often asserted, and I think accurately so, that there are improvements in quality that actually can save money over time because they prevent unnecessary and duplicative care. So we need to figure out, in Florida, we have incredibly high spending levels. And it's been asserted that 30% of American health spending is potentially waste. That is, that it doesn't go toward improving people's health status. But that doesn't mean that you can go into Florida and cut spending across the board by 30% and not hurt people. So we need to be smarter about how we spend our healthcare dollar. And in the U.S., we're talking about starting with a $3 trillion healthcare system. So it's not like we're resource starved. So we just need to figure out how to be smarter about using those resources. What are the roles of utilization and prices? There's a debate about which is more important. I would answer it's both. And we need to look at using our healthcare resources smartly and figuring out better ways to pay reasonable prices for them. Drugs and technology are 2 areas that are particularly controversial. There's been a lot of news in the U.S. about hedge fund managers who acquire drug companies and then triple the cost of the drugs that the companies produce. Those people are rightly getting pressure, and they're being held to account, held to task for that. But hopefully, over time, we can find a more rational way to pay for these things. Can we achieve greater coordination and collaboration without the adverse effects of consolidation? There are a lot of people who are really concerned about the fact that both healthcare providers and healthcare insurers, healthcare payers are consolidating. And that on the provider side, that's raising prices because there are many providers who just say, well, look, you can't do without us in your network, so you have to pay us what we want. Some payers have challenged that and actually lost and found they had to give in. So we have to figure out better ways to do that. And developing policies that are consistent across public and private payers. There's a lot made to cost shifting between public and private payers, and the fact that it's been asserted that public payers, if they start cranking down on what they pay, that private payers will just have to make up the difference, and we have to figure out a way not to have that happen. So again, if health spending did grow at the same rate of GDP over the next 10 years, we would be talking about a fair amount of money still in the healthcare system, although a fair amount that we could save relative to what would otherwise be spent. And it's interesting because, just as an aside, there's been a lot of concern about a decreasing number of doctors and a potential shortage of healthcare providers in the future, which leads me to ask, who's going to spend all that money? But I think people will figure out a way to deal with that. So thank you again for having me here. I'd be glad to take any questions, I guess, if we have time.
There's one at the top here.
Thank you. I was interested to see your $2 trillion graph there. If you aligned on your plot unmet need, how would that traject across that plot in consideration of those savings?
That's interesting. I haven't done that, but I guess one of the issues is not only how much we spend, but how well we direct the money that we spend to meeting the needs of our population, rather than just assuming that it's an impersonal trend. So part of the effort has to be to start meeting that unmet need, and that may involve some cost, but the feeling is that it can be at least offset by improvements in efficiency and effectiveness of our healthcare system.
Thank you.
So I've got one online question here. You mentioned the conversation between quality people and payment people has improved considerably. What do you think facilitated this improvement?
I think the effort to tie payment and quality together, because there's a fair amount of now that resources are involved in the quality issue, a lot more people are interested in figuring out how the two things are connected.
Hi, Stuart. Joe Scuteri. Thanks for a comprehensive presentation. I've seen a few presentations now on the impact of the Affordable Care Act in the US, and it's pretty clear that something's happened. Notwithstanding limitations in terms of cause and effect and, evaluations and contamination, all the rest of it, I mean, you're an expert commentator on the system. I mean, what do you think has been the biggest difference? What's been the biggest change that's had the most impact in terms of accounting for what's happened?
Thank you for that question. I think that there's been a change in the environment in the healthcare system. I think in the US, if you talk to any healthcare provider, they'll tell you that things are different and that they can't keep doing things the way they used to. They're not always happy about that conclusion. But there are so many things going on that I think people are thinking. One example is Peter Orszag, who used to be head of our Congressional Budget Office and also head of our Office of Management and Budget in the Obama administration, points out that he's on the board of a hospital in New York City that has engaged in a substantial effort to try to avoid readmissions to their hospital. And he points out that currently the way hospital services are paid for, that's really an irrational thing for them to do. But the reason they're doing it is that they feel like they have to change, that there is going to be more and more emphasis on providing care efficiently and providing it appropriately. And so they've changed their policies, even though it may cost them money in the short run, because the whole environment is changing. And I think that's what the Affordable Care Act has done, is it's changed the discussion. And there are so many initiatives going on that it's hard to keep track of any one of them, and it's hard to attribute what part of the change has been caused by any one of them. But I think the answer is it's all of them. It's the fact that the environment's changed. And that makes it even more important to kind of sustain that change in environment, because once the conclusion's reached that that change isn't actually going to happen, then policies are going to change back.
Thank you. Is it on? Okay. I'm a big fan of Obamacare, so thank you very much. I enjoy any update on what's going on over there. You touched briefly on changes for fee-for-service. I think the holy grail of healthcare reform is to move away from, fee-for-service, paying for everything, and moving towards to outcomes-based healthcare. I didn't really understand where that was going. You said you were ahead of target, but I didn't really get what that target reflected and how you're actually going to make those reforms, because that's a big one.
Okay, it is a big one, and it's really a massive change. And the efforts that are underway begin with starting to tie at least a piece of the fee-for-service payment to the quality of care. And we have a whole bunch of sets of metrics, quality metrics, to measure that. Things like saying you can share any savings that you receive, but you have to share it subject to improvements in quality. And then eventually move on, and there's a substantial, I think there are different sets of visions about what the ultimate state of the American healthcare system would be following that trend. But the first couple of steps, at least, are to start tying payment to quality, either directly or indirectly, by requiring that providers, in order to get their payment, will have to achieve some sort of quality level or quality improvement.
Just one more. If 101 of economics is that market forces reduces prices, to what extent do prices in the US go up as a reflection of their capacity? So to what extent is the US health market at full capacity?
Well, it's a complicated issue. I think there actually has been a shrinkage of the number of hospital beds in the U.S. over the last couple of decades, I think. But it really varies. There are major hospitals that are kind of must-have providers. There are physicians who are consolidating into single specialty practices that, again, become must-have providers in your network. So it's not really a question of capacity. It's a question of market power, because one of the things I'd point out, I'm an economist too, and I'm a big fan of market forces, using market forces to achieve what you want in policy. But I distinguish between market forces and markets per se. And in the United States, at least, the healthcare markets, and there are two. There's the market for health coverage and the market for health services. They're both broken. And so we not only, there's been a concerted effort. I just read this morning that the Federal Trade Commission, in a surprise, lost a case to prevent a merger between two hospitals. But they've been on a winning streak lately because there's been a lot of pressure to keep consolidation down, to avoid the consolidation of market power. But that's not enough. You really need to change the definition of healthcare and what you're paying for. Because as I like to point out, is not the right term. As I frequently point out, in the US, we get what we pay for. We pay for more services and more complex services, and we get them. So perhaps if we paid for something else that we want more, we would get that too.
I liked your discussion about the ageing of the population and how it might influence costs. Blaming older people for the costs in the system has almost become an art form. In Australia, every 5 years, we blame everything in the future on the fact that we're getting older. We call it the intergenerational report. To actually understand that as the population gets older, a lot of the costs are actually deferred later on, so that 50% of the total lifetime health expenditure is in the last 2 years of life, and except none of us here know when that quite's going to happen. But so as the population ages, does the cost actually, the total population costs, increase that much?
Well, it depends. One of the things in the US that's easy to point out is that every European country is older than the United States is, but its healthcare costs are a third to a half less. So it's not as easy as saying, well, there are too many older people. Also, you remind me of an argument that's going on in the US about Medicare, because it's often said that the US can't afford the Medicare program. And that it's an unfair tax on younger people, who are the ones who pay into the Medicare trust funds from their wages, and a shift to older people. So it's always phrased in terms of an us versus them thing, and I feel like I have to point out that those younger people who are paying in now, they're not paying for the services that are being used by the older people now. They're paying to keep a program alive that's going to be there when they get older. Because unlike many other social problems, the generation battle is really a false structure, because everybody who's young now wants to be old someday. And so they're going to be Medicare beneficiaries. So it's not us versus them, it's us now versus us later, and that makes it much less of a battle. Or in some cases, us now, but that's different.
Jane Hall, and I'm an authority member. I would like to draw you out on some of the comments you made about lots of things going on at once. Because I feel that it's not just a problem for the purity of us as evaluators trying to work out what works, but also for the people trying to implement change. How can you do so much that you don't see anything working because they just don't have the ability to focus on responding to the particular changes? And I guess there are two related parts of that. One is, what should we be doing to give people in the system the skills to change? Because we might get the incentives right, but if they haven't got the management skills to effect change, it's not going to work. And the other is, can we get too distracted on fiddling with the little bits in the system? For us, it's what do we do to the medical benefit schedule, instead of thinking about the much broader question of incentives in the system.
I think that's an excellent set of points. I think you're absolutely right. And you certainly have to be very careful about thinking about what initiatives you want to put in place and whether they really will help to change things. And I have to admit that much of American public policy, certainly in the government health programs, is aimed at, frankly, saving money in the short run. But there are much bigger initiatives, and I think those need to be considered together, not necessarily as a package, because they may play out differently in different areas. But there certainly needs to be a philosophy of these changes, and there certainly needs to be an awareness of how they interact. And the bottom line is the health system going in the direction that you want to see it go? And if it's not, then you figure out, and again, one of the things one of the problems I have with many evaluations is that they tend to, whether the evaluators intend them that way or not, they tend to be viewed as static conclusions, when actually they should be viewed as indications of how you can improve what's going on now, because it's not like you do something for 5 years and then you decide whether it works or not, and then you stop it or you continue it. You have to continually be thinking about how you can improve all of the things that you're doing. And that includes being, some of the things don't work. There's a terrific quote by Franklin Roosevelt that I like to use when I'm talking about demonstrations, where he goes, essentially, he says, you know, we need change, and we need to not be shy in implementing that change. To be sure, some of those changes aren't going to work, and when they don't work, we need to stop doing them. But by all means, we need to do changes. And I think that's the philosophy that needs to be held in developing these policies, is figure out what makes sense to do, try to figure out how to do it best you can, use data to figure out how to improve, and then in the end, figure out if something's just not going to work. That's going to happen. But right now, I think, at least in the U.S., we're very much too focused on a yes or no answer instead of the more dynamic kind of view of these changes.